Another rash-like presentation you'll see clinically is what is referred to as impetigo. Impetigo, the rash you'll see here, isn't like what we've seen previously, okay? Where it was raised red, inflammatory response in the skin around it. No, what you're going to see here is a rather broad area. Could be like, say, along the jawline, across the cheek, down the bicep. The skin will be raised and crusty, dried out looking. There will be areas where it looks like dried pustules. This is due to a superficial bacterial infection that is causing the skin. The inflammatory response will cause the skin to swell, and the outer layers of the epidermis are going to dry off, and the underlying some of the underlying dermis will actually dry out, and you'll start to see peeling away of the epidermis down to the dermal layer. We'll see this is either a Staph aureus infection or a Streptococcus pyogenes. Few patients it may be both. What they've been able to find is that if it's both bacteria causing this, it's a temporal thing, a timing. It starts with pyogenes, but over time, due to the severity, the size, and where the drying rash is occurring, you may get Staph aureus starting to grow into those areas too, and then aureus takes over. It outcompetes pyogenes. Now, as I said, what you're going to see in a clinical setting is this large lesion. Some patients, it'll be small, about the size of a quarter. For most, it'll be an area about the size of your palm. Like I said, it could be on the cheek, along the jawline, chest, the arms, wherever. What's causing this is, well, if it's a staph infection, Staphylococcus aureus makes a weapon, uh, a toxin known as exfoliative toxin A, exfoliative toxin B. What these exfoliative toxins do is they kill the underlying living cells that are holding the outer epidermis to the underlying dermal layer. These cells holding between the two will die, and thus you start to see the peeling away of, for all intents and purposes, the dead dermis, and you begin to see the epidermis drying out and dying also. Now, if it happens to be the Streptococcus pyogenes, Streptococcus pyogenes is also what we refer to as the flesh-eating bacteria. It also, just like Staph aureus, makes its own toxins, also makes enzymes like a hemolytic enzyme that goes through and lyses red blood cells. Strep pyogenes we also see is associated with many other infections depending upon where it is occurring in the body. If you've ever had a strep throat, that's the Streptococcus pharyngitis. Pneumonia, it's also been shown to cause bacteremia. Bacteremia is a bacterial infection of the bloodstream. What we see is due to this large selection of enzymes and toxins that Streptococcus pyogenes has at its disposal, there's going to be some secondary issues beyond just the lesions, the rash associated with the lesions. These toxins These enzymes will be carried away by the draining lymphatics, will get into the bloodstream, be carried throughout the blood. You see here in the second bullet, glomerulonephritis. Wow, cannot say that one today. Glom, the nephritis is actually an inflammation, damage to the kidneys. Patients will start getting kidney damage almost to the point of kidney failure, all due to a strep infection of the skin. The timing of when the infection occurs and can help the clinician down the path to determining what the possible causative agent is. If we're looking at impetigo and it's newborn baby, newborn to infancy, Streptococcus pyogenes is more often than not the causative agent. Older children to adults, you're looking more of a Staphylococcus aureus infection. Now, if in a clinical setting a baby shows up or a young infant shows up and they have impetigo, does that mean it is strep pyogenes? No. You have to keep in mind that for most of medicine, most clinical practice is basically playing the odds. If you are presented with a patient suffering from disease or infection A, then here is the list in ranked order of the top 5, the top 10 causative agents. And that's how you treat them initially until you get information back from the infectious diseases lab at either LabCorp or from the hospital lab itself.